Hi, everyone. Thank you for joining today's presentation, Essential Insights on Colorectal Cancer. Today, we're fortunate to have colorectal and general surgeon, Dr. Anthony Squillaro, here with us to discuss the mechanisms, risk factors, prevention strategies, and treatment options for colorectal cancer. Before we get started, I just would like to share a little bit about our organization for those who haven't joined our programs in the past. Community Health Resource Center is a nonprofit organization here in San Francisco. We were established nearly 4 years ago by doctors at California Pacific Medical Center to provide resources and care that would supplement their work with patients to support their overall health and well-being. Today, we provide 4 main areas of service. Those are social work, nutrition counseling, community health screening, health education. I would like to go ahead and pass it along to Dr. Squillaro to introduce himself and dive into the presentation.
Thanks so much, Lily, and thank you to our Sutter CPMC cancer nurse navigator, Nicole, as well as the Community Health Resource Center to provide this venue for a topic that I'm sure you all read lots about in the paper of late, and you likely know family or friends that are affected by colorectal cancer. So I'm a colorectal surgeon at Sutter CPMC. In a private practice called San Francisco Surgical. We're the one of the longest standing colorectal surgery groups in the city here for about 80 years. And we almost exclusively work here at Sutter CPMC. My group has brought endoscopy or colonoscopy here to the city way back in the day. So it's an area that we are that's near and dear to our hearts here and to the community. So first, I'm going to start with, I don't have any financial disclosures to report. The presentation focuses on the most common colorectal cancer, that's adenocarcinoma. There are some other types, but I won't go into those. And then this presentation is not a replacement for individual medical expert counseling. And I think any of us are happy to do that for you if on an individual basis, if need be. So the objectives are looking at what's the epidemiology or the incidence and prevalence of colorectal cancer, as well as some of the biologic foundations, why we get this, the clinical presentations of colorectal cancer, screening, which is going to be one of the most important topics of this talk for colorectal cancer, and then treatment. Treatment will be a little bit more broad stroke, and treatment is so nuanced nowadays, especially for things like rectal cancer, that I will go over sort of the broad of surgery, chemotherapy, radiation type stuff. So how common is colorectal cancer? Well, the top 3 for decades seem to be always kind of in competition between lung cancer, breast cancer, and colorectal cancer. Prostate cancer is a close 4th usually. But when we look at men and women, colon cancer invariably affects both at almost the same rate, a little bit more in men than women. One of the most alarming things, and this is probably what you've seen, there was a New York Times article about it recently, is the increasing incidence. So it's increasing in those individuals under 50 years old. And I'll kind of go into that. We don't exactly know why, but even with increased screening, colonoscopies, stool-based tests, why is it that we're seeing this in under 50 years old? 1 million people worldwide. Incidence is declining for those over 50 years old, and I'll show some graphs on that, and that's a good thing. So that means that screening is working. So that's a good thing. And then rectal cancer is especially increasing in under 50 years old. So 1 in 20 people on average, that's probably on the higher end of the spectrum. It's usually about 1 in 23 for men, 1 in 25 for women. So pretty common, breast cancer for women, about 1 in 10 to 12. So, colorectal cancer, pretty close second to that, very, very common. But the good news is that when you look at GI malignancies, so other GI malignancies, pancreatic cancer, gallbladder cancer, stomach cancer, survival is better for colorectal cancer. It's something that we can take on, we can cure, we can beat. And then the best thing about it is, out of any of the cancers that we deal with, there's an excellent screening and preventative test or procedure, and that's colonoscopy, to both screen, detect a colon cancer, or detect precancerous polyps, remove them so that they'll never ever be cancer. And that's the only type of test or procedure for these type of cancers, for cancers that has the best efficacy. So this is just our U.S. surveillance data on how common colorectal cancer is in the country. And so every year, new cases of cancer in 2024, this is that breast cancer being the highest. This is only looking at women. And prostate cancer would be for men, lung and bronchus cancer, and then colorectal cancer. So lung and colorectal cancer equally affecting, men and women, or, affecting men and women. The top two only on one or the other usually. And then you can kind of see what kind of comes up in the close top 10. I wanted just to point out that when you look at other cancers, including pancreatic cancer, new cases are 66,000, but deaths are almost that high. Whereas if you look at colorectal cancer, new cases 150,000, only about a third of those are deaths. So I think that's important to know, that it is a treatable and curable cancer. So these are the numbers of the new cases per year for colon cancer and rectal cancer. And you may ask me, what's the difference between the two? And biology-wise, they're almost exactly the same. It's mostly by location. Sometimes rectal cancer can be more aggressive, but we'll kind of go into a little bit more of the nuances as that. Both colon and rectal cancer is slightly more prevalent in men. It's slightly more prevalent in Hispanic and Blacks, as well as Native Americans as well. So here are really the crux of the sort of incidence and prevalence epidemiology for the past, let's say, 50 years. So I'm going to point your attention over to this top left over here. This is colon cancer, and then this is rectal cancer. Red is ages under 50, and over on this side, and red over here is ages over 50. So first, let's just look at this side. This is the older age. And so when colorectal cancer screening kind of first started, over 80–90% of colorectal cancer occurs in people over the age of 50. So in 1979, when screening in the U.S. Preventative Task Force suggested that screening started at age 50, that's why that they recommended that. And you can see that here in this plot is that at 1985, so 1979 is here, 1985 is over here. You can see that actually since 1985, colorectal cancer is going down for those individuals over 50 years old. But the alarming thing, and this is the thing that you'll see in the newspaper articles lately, is that in 1995 here, people under 50, and this is broken down as red being, it's a little confusing because there's red here and red here, but those under 50 and those specifically ages 20 to 49, there's actually an increase since 1995 in colon cancer. The same thing is true when you look at rectal cancer, okay? The incidence of rectal cancer is lower than colon cancer, but you can see that the trend remains the same. And sort of the shocking thing is that if you were born in sort of the millennial time period between 1981 and 1996, you have twice the risk of colorectal cancer than those born in the 1950s. So what are we doing wrong, or what's going on? We instituted screening in 1979 in this country as part of our official recommendations, yet the incidence is going up, but it's specifically going up in those under 50. And that's really the thing that's gotten a lot of attention lately. These are some of those arrows just pointing to those inflection points where you can see that both colon and rectal cancer is going up in those under 50. And unfortunately, the mortality is also going up. So in those patients under 50 years old, these graphs are showing that actually the mortality, people dying from colorectal cancer under the age of 50, is going up 1% per year. And one of the things that I think that New York Times article and others have talked about is that by the year 2030, this should be the #1 cancer killer, cause of mortality by 2030 for both men and women. So there's a big problem going on. We know it's going on, and so let's take a look at sort of why it may be going on, both challenges and both the risks for colorectal cancer. So kind of honing in on the early onset, because that's the most of late topics, is that this group of people, if you notice that the screening guidelines in 1979 said 50 and up. In our country, we only changed colorectal screening guidelines to 45 and up in 2021. And so there's a lag behind identification and treatment of that. Just like you saw on the graph before, that 1979, it took until 1985 for that inflection point for the decrease in colorectal cancer to go down. It's the same thing happening now with those under 50. Only 1 in 5 are up to date in screening. Under 45 years old, there is no routine screening recommended. You are not supposed to be routinely recommended for screening. It's not covered by insurance unless you have a change in bowel habits, rectal bleeding, or other GI symptoms refractory to other diagnostics. You know, for colonoscopies and stool-based studies like Cologuard, this is all covered by insurance as long as you fit the US guidelines. But it's those people outside those guidelines that we're trying to understand. The problem is that if you have symptomatic patients under the age of 45, they are often dismissed or misinterpreted. Hemorrhoids, fissures, IBS, diverticulitis. These are the kind of things that I hear when patients come to my office from their PCPs or things like that. And this delay in diagnosis has serious consequences. And I think this is why you see the mortality going up 1% year by year, is that this delay in diagnosis kicks the can down the road to a later stage of disease. So more than half of the patients with early onset colorectal cancer under the age of 50 wait up to a year from the onset to seek medical care. They're evaluated by an average of 3 medical providers before diagnosis. And I can tell you anecdotally that I have seen this recently, okay? So how do you get colorectal cancer, okay? Is it genetic? Is it sporadic? Do you have to have a family history? Is there something you're born with? Well, 65% to about 80% is sporadic. Nobody in the family had it. There's a genetic mutation. It's called somatic or acquired over time, and polyps that grow in the colon turn into cancers. But 25% have a family history of colorectal cancer. And so those patients, I put a little star around, these are the patients that give us a little signal, right? This gives the primary care doctor and the colorectal surgeon, the GI doctor, a signal that on that history that we take, these are the people that we really, really need to also hone in on, especially if they're younger. Those with hereditary cancer, that's a special population that's a little bit beyond the scope of this talk, but those are for people who have things that they have polyposis syndromes that they're inherited from their parents in what's called a dominant fashion. So if one parent has it, then you have it. And then those people have either hundreds or thousands of polyps. Some people don't have that many polyps, but they have something called Lynch syndrome. A little bit beyond the scope of the broad strokes of this talk, but certainly can answer any questions about it later. So why does this occur? Well, the two theories, sporadic, which most of it, and inherited. Sporadic, these are sort of the risk factors that we traditionally think about. We don't know exactly. We know from epidemiological studies, so that means broad thousands and hundreds of thousands of patients, and we look back retrospectively in time, we see, did those patients, were they smokers? Were they older age? Did they have something like Crohn's or ulcerative colitis? And how about obesity? What is their BMI? The only scientific lab studies that we have are a lot in mice and rat models where they gave them high fat diets or red meat or things like that, where they saw direct injury to the colonocytes or the cells of the colon. And so from these very small animal models, this is why we often say avoid red meat, eat a high fiber diet, although it is not completely certain that that is the reason. I just want to, let you guys know that it's not completely certain. A lot of that is extrapolated from small animal models. But one thing we can't really deny is that the epidemic of obesity in this millennial generation in the 1980s, 1990s, that we're seeing an increase in colorectal cancer as well as other diseases, that is a very different type of thing that we hadn't seen in the decades before. And so we think that there's a lot of link to that, just like many other diseases. Inflammatory bowel disease is a special type of disease that's an autoimmune disease. It's either Crohn's disease or ulcerative colitis. And those diseases you're born with, they're not acquired, but those have chronic inflammation to the lining of your colon and sometimes your small intestines, leading to injury and then to a higher risk of colorectal cancer. So those patients, they have to go more frequently for surveillance and they have a higher risk of colorectal cancer. Specifically, those with ulcerative colitis can have up to a 15 to 20 times higher risk of colon cancer than those who don't. So these are some of the acquired things that can happen over your life that cause sporadic colorectal cancer. For the inherited, these are things like family history of genes and certain traits that they end up expressing mixed in with environmental changes later that then trigger these genes. And I'll kind of go on to the next slide to show you that this is, I just want you to pay attention to the cartoons here of what the normal colon looks like and moving from left to right from normal to an at-risk lining of the colon to polyps, looks like a lollipop here, or this looks like a shag carpet, down to invasive cancer. And I'm not going to go into the details about all the genetics, but this is a cancer, colorectal cancer is something that is a model that is very well known, that you have to have what's called the two-hit hypothesis. So we know that there's a gene, the APC gene, and that gene has to have some mutation, whether it be you're born with it, given to you by your parents, or was acquired. There was an injury from dietary, obesity changes, smoking. That happens first to the normal colon. If that mutation happens, then that mucosa is at risk, and then you have some inactivation of normal genes, and that's the second hit. And when that happens, polyps start to grow. Polyps are division of colonic cells. Your colon cells are dividing every single day and turning over. And when they lose those little gene signals that maintain the healthy lining of the colon, that's when polyps start to grow. And polyps are very, very common. 35% of us in men have polyps and 30% of us in women have polyps. So it's a very, very common process. They take years to form. It is when they get larger, so usually proportionally when they get larger, they become invasive. There are some exceptions to that based on their biology, more aggressive biology, but usually polyps, proportional to their size, have a higher risk of an invasive cancer. So this is a very well-known entity, and this is why we are so good at treating colorectal cancer and curing it because we understand the biology and the progression. And we understand that it does take years and years and years for this to happen. And that's why most people are over the age of 50 because it does take years to form polyps. So what are the signs and symptoms? A lot of people are asymptomatic actually, and they're found on screening. So they turn 45, maybe they're in their 50s and their 60s. The average age that it's detected is usually 72. So it does take some time to go from polyp to cancer. And they're asymptomatic. And, myself or GI doctor would be doing a colonoscopy and we'd find a polyp, we'd remove it. Or if it was too big to remove, we'd biopsy it and then you could find cancer in it. That's how most of them are found. Those individuals that haven't had a screening colonoscopy and have them in their 70s, 60s, and 70s, they're going to be the ones that are more likely to have bigger polyps and then a risk of a cancer versus those who start screening at 45. Patients that have sort of constitutional symptoms or systemic kind of vague symptoms sometimes, weight loss. Now I'm talking about 30 pounds in about 3 to 6 months, okay? And you're not dieting or exercising or anything like that. Fevers, night sweats, not as common, honestly. Mostly it's weight loss, fatigue, and abdominal discomfort. And a lot of people are, they just discount it as this is I've had irritable bowel, or I ate something weird, or I traveled somewhere and I just haven't been the same. I traveled to India and I haven't been the same, that kind of thing. And so those are the type of symptoms that people report. Bleeding and on bowel movements, you'd be surprised. They're generally more advanced, or the polyps or the cancer are larger when people actually have rectal bleeding or bloody bowel movements. Anemia or low hemoglobin, low red blood cells on routine labs can also trigger that. So all rectal bleeding is abnormal. And so I'm going to say it again. All rectal bleeding is abnormal. It is never normal to have rectal bleeding. But most commonly, rectal bleeding is from hemorrhoids or fissures, most commonly. So most of my clinic every single day is mostly with people with hemorrhoids. And most of it you'll see is what you see on the left. You'll be using the bathroom and you just see blood on the toilet. And, you think it's like a horror film when you see it, but this is actually, in my mind, more reassuring than if I see blood clots or darker blood, because that means that blood is coming close to the exit, right? It's coming from the anus or the distal rectum. Hemorrhoids like to live in the anus and the distal rectum right there. And so most patients that come to me with rectal bleeding have this, or if they have blood on the toilet paper. And so that is a very common thing that people come every day to see me and a colorectal surgeon and GI doctors. It's when you start having darker blood called melena or blood clots mixed in with bright red blood that's when we become a little bit more concerned. And I'll tell you why. If you have bleeding closer down to the rectum, there's less time for it to mix with stool, less time for it to oxidize, and thus bleeding that happens down by the exit there is more red. Bleeding that from a polyp or from a cancer that occurs on the right side of the colon, sometimes you don't even see this. This is called occult bleeding. And what you'll find on regular labs is that you have an anemia. Your hemoglobin is low. Or you have just a darker shade of stools. You may not even notice it, but a darker shade. When you have a cancer on the left side, colon cancer on the left side, you generally have change of bowel movements, because this is the part where you're starting to propel stool out towards your rectum. And this is more of a high pressure zone, you're forming stool. And so you start to have changes in the caliber of the stool. Maybe you have more constipation, or you have irregularity where you have a loose stooling as stool is going through a tight, stricture of a cancer. These stools will be a little bit more bloody. You'll also tend to get bowel obstructions over here. Now that's an emergency, and people, uncommonly come in like that, but that is something that happens on this side. For rectal cancer, the symptoms are a little bit different. There tend to be this feeling of tenesmus. And what is that? That's incomplete, the feeling of incomplete evacuation. So when you go and you defecate and you go and you just feel like you haven't gotten everything out. That's what tenesmus is. Rectal pain can occur when that tumor is very close to the anus. And that's when you start to have those sensory fibers by the anus, because that's skin down there. Hematochezia is coating the stool with blood, and then stool caliber change. So a lot of my patients will say to me, well, you know what? I used to have, regular bowel movements and now they're thin like a pencil. That is something for me that's always an alarm that goes off in my head. So, by location, these are the symptoms. So bright red blood per rectum is going to be things right here towards the outlet. But for the right side and transverse colon, these are different kind of symptoms. So these are anemia, these are fatigue, these are change in bowel habits, those kind of things. They're not rectal bleeding, not bright red blood. And so it's really important to know that even vague GI symptoms can be a right-sided colon cancer. It's very, very, very important. So how do we detect this? Well, we've got great screening methods. Like I said, mammograms are great. Chest x-rays are okay for lung cancer, not super great. But for colorectal cancer, we have stool-based tests that are not invasive. All you have to do is provide a stool sample, or direct visualization. And those are invasive. And so I'm going to go over a few of them because this is a really important point. So there's the fecal immunochemical fit test, it's called. And this looks for an antigen to blood, to hemoglobin in your stool. This has to be done annually for its best effectiveness. It's about 70 to 80% sensitive to pick up a cancer. And it's a good test, but it's not one that I routinely recommend to patients if they have the ability to get better tests. Stool DNA tests are ones that look specifically, this is an at-home test, it's prescribed by your doctor, and you give a stool sample and you send it off. Every 3 years is generally what's indicated. And this looks for specific DNA aberrations or injuries that are shed into the stool that indicate colorectal cancer. And they have a pretty good sensitivity, but they do miss 1 in 12 colorectal cancers, or they have a false negative rate of 8%, which in my mind is a little too high for comfort for me. But they're a good test. They're a great test for someone who does not have access to colonoscopy. They are not a good test for people who have family history of colorectal cancer. They are not indicated for that, or polyps. They are not indicated for anyone with ulcerative colitis or Crohn's disease. And I want to make that point really explicit. If your primary care doctor orders this and you have a family history of colon cancer, that is not the right test, okay? The right test is direct visualization or colonoscopy. Flexible symbionoscopy is something that PCPs and early colorectal surgeons and GI doctors would do, but now that's just looking at the first 20, 30 centimeters of the rectum and the colon. But now we just do a full colonoscopy because we can visualize the entire colon. And the benefit is that we can diagnose and we can remove precancerous polyps. CT colonography is a test where you drink a contrast and we get a CT that reconstructs what the colon and the rectum look like and looks for abnormalities that could be a cancer. About 80 to 90% effective for picking something up, but again, not therapeutic. So if a colon or if a cancer is found or a polyp, it cannot be removed by that. So colonoscopy is the gold standard. And this cartoon just kind of depicts all the different types of tests, okay? So colonoscopy is the entire length. It is the gold standard. The stool tests are send-out tests, and the flexible sigmoidoscopy is just the lower. So this is some of the data on Cologuard. So this is probably our best stool-based test. And what I want to point out is that it's really good in detecting early cancers, but it's not great in detecting later cancers. And it's not great in detecting polyps. So if you look at this graph here, and this is from the manufacturer's website, if a polyp is 2 centimeters or over, you can see that the sensitivity of it picking up of Cologuard test being positive is about 65%, okay? Versus a colonoscopy, which is well into the 90%. It's very hard for me to miss a large polyp on a colonoscopy if it's large. It's very, very hard to miss. And so what I want to reiterate again is that Cologuard misses 8% of cancers. You will get a false negative on 8%, and that's in their trials that the manufacturer ran. So the best test still is colonoscopy. And I understand there's anxieties around this test, and I know the bowel prep seems daunting and you're going to be running to the bathroom, but trust me on this one, it's easier than you think. I'm not 45 yet, so I haven't had one. I can't say that I've had one, but the bowel prep now is no longer drinking the gallons and gallons of liquid and getting nauseous. We actually use, in my practice, we use pills. And so we'll use about 2 sets of a dozen pills and 16 ounces of water times 2 usually. And you'll drink the pills, and the pills will be a cathartic, and you'll get rid of everything. So you don't have to drink the liters and liters and liters anymore that used to, scare people. You're asleep during the procedure for the most part. Most of the colonoscopies that I do and my group does is that you have propofol anesthesia, and you have amnesia to the event. You don't remember it, but you're breathing on your own and you don't feel it. Okay. As soon as the anesthesia is withdrawn, you're awake in about 15 to 20 seconds. You're groggy, but you're awake again. And so this test, although there are a lot of anxieties around it, I can assure you it's commonly done. It's got the highest sensitivity. It is the gold standard in our country. And it has gotten better over time, both in the ability to detect polyps and cancer based on the technology of seeing with the colonoscopy, as well as the bowel preps. So how often do we have to do a colonoscopy? Well, since 2021, and the screening age is now pushed to 45, closer to 45, and that's because of the fact that there is an increase in colorectal cancer under the age of 50. For people with severe inflammatory bowel disease, this is a different group of people, and it's a little bit more nuanced. They'll go as frequently as every 1 to 2 years, but it'll get spaced out as much as every 10 years. As if you have a normal colonoscopy at age 45, then you don't need to get another one for about 7 to 10 years. And that's the US Preventative Task Force guidelines on that. When do you need to have colonoscopies up until? Well, we say age 75, but I'll be honest with you, it depends on how you are when you're 75. I've met people who are 80 that look like they're 65, and they're still going out and doing things and hiking and things like that. And for those people, they would benefit from a colonoscopy. So the national guidelines are that, there's a decline after 75, and that's with looking at hundreds of thousands of people. But there's not much of a benefit over 85 years old. And that kind of makes sense, right? So if you got your last colonoscopy at 75 or 80, by the time you're 85, it takes years and years and years for polyps and cancer to form. So it really doesn't, the benefit really kind of wanes after 85. It's a safe procedure. So what are the 2 biggest risks of the actual scope? And that's perforation, which is under 0.005%. Risk of bleeding well under 1%. Mostly that risk comes from removing large polyps or being on anticoagulation. Risk of anesthesia is about 0.1%, so aspiration and cardiac events, but very, very, very safe, okay? A special population, I know there was in the Q&A prior to this, is people with diverticulitis. Do they need to get colonoscopies? Well, it depends on what flavor of diverticulitis you have. If you have what's called complicated diverticulitis, and that's people that have more severe versions of diverticulitis, they need to get a colonoscopy after their diverticulitis resolves because they have a 2 to 6% incidence of a lesion that may have caused that, or an incidental lesion as well. So that's a special population and done, on a case-by-case basis. So this is just the overall graph that shows that how good is each of these tests, okay? And so colonoscopy is right here, 95% sensitive for picking something up. FIT test, this is the one you got to do every single year. It looks for that antigen of hemoglobin, 73%. FIT DNA, this is the Cologuard test. This looks for the DNA shed by tumors and large polyps. But I will tell you that for large polyps, 1 centimeter polyps, it has a pretty poor detection rate, 42%, versus a cancer, 92, okay? So this is just sort of the overall how good each test is, okay? So now moving on to briefly, but treating colorectal cancer, I'll tell you that colorectal cancer has become extremely nuanced of late, especially rectal cancer. Nicole and I can tell you that based on our bi-monthly meetings in a multidisciplinary tumor board for rectal cancer, that every patient is treated different. But what I'm here to say is that colorectal cancer, by the numbers, by these epidemiological numbers and survival numbers, is treatable, and it's often very curable. Even metastatic colorectal cancer in a metropolitan area like San Francisco is treatable and can be curable. So I want to let you guys know that in terms of other malignancies, this is something that you can beat, okay? So who treats colorectal cancer? Well, the surgeon cures localized cancer. So if that cancer is confined to the colon and it has not spread to the liver, the lungs, and maybe it's in some of the lymph nodes, a surgeon can remove that and cure it. A medical oncologist, they cure cancer by giving chemotherapy. That's usually done either before or after surgery. For people who have metastatic cancer, in other words, cancer that's gone to different parts of the body that it's not the colon, usually the liver and the lung, oncologists can also give what's called palliative, not curative chemotherapy, but they can also give palliative chemotherapy to hopefully delay progression of disease. And a radiation oncologist is a special type of radiologist that uses usually external beam radiation to attack usually rectal cancer, okay? So here at Sutter CPMC, we are the only nationally accredited program for rectal cancer in San Francisco. We're one of the few in Northern California. And what does this mean? This means that we are held to very stringent standards by the American College of Surgeons, the American College of Surgeons being the body of the governing body in America that board certify people like me as a surgeon and many other surgeons that hold rectal cancer treatment, the diagnosis, management, and treatment to the highest standards. And that multidisciplinary team, for every patient that has rectal cancer and colon cancer, we have cancer nurse navigators. That's Nicole Adler, colorectal surgeons like myself, GI oncologists, radiation oncologists, and GI pathologists. And you know, this is something that we do together. So we do not make these decisions in isolation, and every patient is different, and every patient is nuanced, and that's why we bring everyone together. So this is a very simplified view of colorectal cancer treatment. So you get a diagnosis, and once you get a diagnosis of colorectal cancer, you have to name the cancer. So name it as colon or rectal cancer. Then you have to stage it. How advanced is it? Is it local? In other words, is it confined to the colon and we can remove it? That's curable. Is it metastatic or incurable? And that's sort of the quick gist of colorectal cancer treatment. It's often difficult and imprecise to stage something preoperatively. You have to usually detect if there's any big spread anywhere, usually the liver, the lungs, take biopsies. Predictive factors based on the biology. How does that tumor behave? Is the tumor behaving very aggressive or not at all? And so we make, and these tumor board that Nicole and I sit on, we make these conjectures and these estimates, and it's often very hard. But broad strokes, and this is a busy slide, these are, and feel free to take a screenshot of it. This is from the one of the American Journals of Cancer. This is, the American Joint Commission on Cancer, the AJCC. This is broad strokes how colorectal cancer is staged. And then I think what's really helpful is that on the bottom, so stage 1 being confined to the colon, stage 2 being also confined to the colon just a little bit deeper, stage 3 now spread to the lymph nodes, and stage 4, this is now metastasized or left the colon and lymph nodes and have gone elsewhere. think what's really important to see is that the survival rates are on the bottom, so that if we catch this early, and what does that mean? Well, if you look, early in my mind is that if we catch something between stages 0 and 3, 1-year survival is in the 90%, 5-year survival for stage 3, that's in the lymph nodes, being 70%. That's a very good outlook versus it drops rapidly to 13% at 5 years for metastatic cancer. So these are the folks, stages 0 through 3, hopefully not stage 3, but stage 0 through 3, that we try to catch on colonoscopy. Those are exactly the people that we know we can beat cancer. Okay. So what's surgery for cancer like? I'm going to try to go through it. Again, this is nuanced. I'll try to go through this, so leave time for questions. The goal is to remove the primary tumor and at least 5 centimeters on each side to get the lymph nodes. And you may ask me, well, Dr. Squillaro, why do you have to go 5 centimeters on each direction? Why can't you just remove that tumor? Well, I'm an Italian, so I always think about food. And so one of the things is, think about it as a slice of pizza. So you don't know what the pizza tastes like if you just eat the crust. Now the crust is, think about it, is the tube of the colon. And this wedge here and this cheese is the fat that you see of the mesentery. It's the mesentery of the colon, and all the pepperoni on there is the lymph nodes. And so you have no idea what that piece of pizza tastes like unless you get a nice slice of it. And so it's the same thing in colorectal cancer, is that when you remove the tumor, you have to take that wedge and get a sample of all the things in the fat, which are the lymph nodes, look at all the veins, the nerves, and the blood vessels to understand what stage that is. So that's often why when I tell a patient, well, I have to remove this much, that's why we have to remove this much. We can't just remove just around the tumor, which is different than other type of cancers. So how do we do it? This is just a slide to show that we, in 2024, we used the robot to do a lot of surgery, and that enhances recovery after surgery. It allows us to take an ugly tumor like this that I removed a couple months ago, that's growing into the abdominal wall. This is the right colon, using robotic arms. And this that you see right here, after it's taken out, is this right here. Okay. And doing it through 5 small incisions, about 8 millimeters, or about half an inch each. And that quickens the recovery for patients. And so this is something that my group here is a high volume of robotic surgeons that we do here at Sutter CPMC and San Francisco Surgical. So chemotherapy is not my domain, as I'm not an oncologist, but why do we do it and what's the benefit? Well, the key step in colon cancer staging is determine, is there spread? Is stage 3, is there spread to the lymph nodes? That means that the cancer has gone to the slices of pepperoni on the pizza. So the only way to really know that mostly is by surgery. So removing that wedge, that slice, analyzing it in the lab, and taking a look. In those patients that have lymph node involvement, there is a survival benefit if they get chemotherapy afterwards. Now, I'm not going to go into the nuances of rectal cancer. That's a whole nother can of worms. But broad strokes for colon cancer, patients can enjoy up to a 25% increase in their survival benefit from our current chemotherapy modalities. And that's 5-fluorouracil on oxaliplatin, or FOLFOX therapy, which is the our National Cancer Center Network's guideline goal-directed therapy for that. So that's why when we add chemotherapy, okay? So just going over, patients always ask me, well, what is my survival? This is that. It's hard to give point estimates for everybody, but in terms of our SEER guidelines, and this is our U.S. surveillance that looks at hundreds of thousands of databases in the U.S., 5-year survival is 65%. For those with stage 1 cancer, it's 95%. For those with stage 3, it's 70%. For those with stage 4 to the liver and the lungs, between 15 and 25%. So every patient is different. This is showing survival by percent of cases by stage. So localized, confined to the primary site, most of them are localized or regional. So most of them are stage 0, 1, 2, or 3. Stage 4 is about a quarter of those. People that are unknown is 6%. These are the ones we want to detect on colonoscopy. If we can do that, we can beat the colorectal cancer, okay? And then again, this is sort of the 5-year survival. So localized, these are stage 1 and 2. Regional, this means this is, so localized, again, this is in the pizza crust. Regional, this is in the pepperoni, right? Or in the fat of the cheese. Distant, this is now in the liver and the lungs, okay? And lastly, because all of you coming from the community, your first point of contact is a primary care provider. The role of your PCP is extremely important, okay? Alarming symptoms should be brought up at all times. Advocate for yourself on repeat visits if you have continued GI symptoms. If something is not right, you have things that are irritable bowel that are just not going away, and you've tried, laxatives, or you've tried fiber, just advocate for yourself. There's no harm in doing one of these stool-based tests or colonoscopies and knowing for sure if something just doesn't feel right over several encounters with a PCP or a GI doctor or colorectal surgeon. A PCP is a great first step in colorectal cancer screening. They'll be able to give you the stool test or the colonoscopy referral, as will I or any GI doctor. Hemorrhoids and rectal bleeding, something that is very common in our practice here at San Francisco Surgical, that we see multiple times every day. I believe that all of our PCPs should hopefully refer to our colorectal surgeons upon first presentation, because even if it's just hemorrhoids, great, we'll help you there too. Okay, so I just want to say thank you so much to Lily and Nicole for inviting me to this venue. I hope that the community that's here is that this is helpful for you, and I hope that I'll see you for a screening colonoscopy if I didn't convince you yet. Our numbers here down here and our websites here. I'd like to go over some questions if I'm hope I can answer them. Again, your specific case I may not be able to answer in this public forum, but happy to follow up individually.
Thank you, Dr. Squillaro. That was great.
Thank you.
I will start to kind of present questions and we can hopefully get through them. The first question I have here is stomach cancer different from colorectal cancer? If not, is there a test for stomach cancer?
And, often the GI tract cancers can look the same, but the cause of them between colorectal and stomach cancer is very different. For stomach cancer, generally we think about things like risk factors like smoked meats, smoking, drinking, that kind of stuff, injuring the lining of the stomach, as well as chronic ulcer disease from something called H. pylori, which is a bacteria that causes ulcers in the stomach. And so that's a very different process than colorectal cancer. So no, they are not the same.
Thank you for clarifying. Let's see. Why would a polyp or residual matter not be removed during a colonoscopy?
Great question. So we always strive to remove everything. Now, if something is large, so we're saying like over 2 centimeters, we often just biopsy it first, get its biology, look at it under the lab, under the microscope, and then usually plan for an advanced planned resection of that. And our advanced GI doctors here at Sutter CPMC are some of the best in Northern California that actually end up doing a lot of them. Where they can, they can actually, we use a knife through the colonoscopy and actually remove it around circumferentially. Sometimes when it's not removed can be that, during the process of removal, a very small microscopic amount that is not detected by the endoscopist may be present on the margin. That is possible. Also, the other thing I'll tell you is that if the bowel prep that you take is not what we call adequate or not clear, it's very hard to detect something under 5 millimeters or so. So 5 millimeters, very, very hard to see something if there's stool in there. So that's why bowel prep is essential to be able to detect things that are small.
Thank you. Next, this question, you've already sort of went over the beginning part of the question. I'll read out the full one, but I think the end of the question is really something that you might be able to address here. What are the best prevention methods or diets? I know you kind of talked about that already. And what options are there for patients with Lynch syndrome?
Okay. So I'll kind of go over the prevention methods again, either a stool-based test or colonoscopy. Colonoscopy is the only one that can prevent, right? So that's the one where you can see a polyp and you can remove it, a polyp that's precancerous, and remove it. That is a very active way to prevent something. In terms of what you can do every single day, the theories that we have from these mouse and rat models in the lab is that eating a high fiber diet doesn't hurt, and it may be helpful as well. Avoiding red meat is said as well, because it's said that in those sort of animal models, red meat can induce injury to the colon, the lining of the colon. An injury produces inflammation, produces increased production of colon cells, and increased production eventually with a genetic injury there will cause a polyp and then cancer. Lynch syndrome is a little bit beyond the scope of this broad stroke talk, and Lynch syndrome is it is a hereditary colorectal cancer. So it's in one of those 10-ish% of colorectal cancers where it is passed down from parents and generations. And so that's a little bit more of a specific question for those individuals. Genealogy and looking at family trees is extremely important. So knowing people who have a colorectal cancer that's a first-degree relative, that you've had 3 of them, and that one of them has been diagnosed with colorectal cancer under the age of 50, that's called the Amsterdam criteria of hereditary non-polyposis syndrome, or Lynch. So that's a very, very important thing. Knowing what your family history is really important. And then we have some special tests for gene defects for Lynch syndrome too, as well. But in terms of prevention, it's really knowing your family tree and who in your family has had colorectal cancer and at what age. That really helps guide GI, colorectal surgeons and oncologists to then get genetic testing after that.
Got it. Thank you. Why would someone be awake during a colonoscopy? It sounds like this person has heard of some people not being fully asleep.
Yeah, I asked, like, I wouldn't want to have this done awake, but that's not to say that it's not done, okay? Some people do opt to do it awake. It's completely okay to do that. It is a little bit more difficult for the endoscopist because you are going to feel it. And so when you feel it, the colon will often spasm and it will be difficult to kind of get through. People often, if they want, so first of all, it's not common that people do it awake. But if they do want to do it awake, it is usually because they want to avoid anesthesia, even though anesthesia is very safe.
Got it. Thank you. Last question in the Q&A. Do we need to request for pills versus liquid to prep for a colonoscopy, or is this the standard now?
So there's high volume liquid preps, low volume liquid preps, and pills. And so it just depends on what you can tolerate in terms of your let's say other medical issues. So for people who, let's say, have kidney disease, they're usually not using the low volume or pills. They're usually using a higher volume prep. It just depends on the patient. In terms of success of cleaning you out for colonoscopy and ease of use, the pills have been shown to be easier to use and have a very good, detection rate on the inside lining of the colon.
Thank you, Dr. Squillaro. Yeah, I think we'll just need to go ahead and finish the session here. But like Dr. Squillaro said, please feel free to direct any questions to us. And once again, I'd just like to thank everyone for joining Sutter Health, CPMC Cancer Services Department, and Community Health Resource Center for this presentation. Thank you to Dr. Squillaro for taking the time out of your busy schedule to present on such an important topic. Thank you to Nicole for helping to coordinate and connecting us with Dr. Squillaro for this presentation. Everyone, feel free to keep an eye out for emails regarding upcoming presentations. And thank you all again. I hope you have a great evening.
Thank you, Lily and Nicole.
Take care.
Bye. Thanks.